Morning, everyone. Welcome to the Journal Club for April. I hope everyone had a great March. So we'll get started on our studies. All right, so once again, welcome everyone to the Orlando GI Journal Club for April. So our first study in our Journal Club today is a study looking at artificial intelligence and colonoscopy experience, lessons from 2 randomized trials by Rapucci et al. In gut. Adenoma detection rate is a proxy for competence of the endoscopist and is inversely related to the risk of post-colonoscopy colorectal cancer. Artificial intelligence has been shown to increase the adenoma detection rate by 30% and adenoma per colonoscopy by 46% in a randomized trial of expert endoscopists that the authors have performed previously. However, the influence of examining expertise versus artificial intelligence on the adenoma detection rate is not yet known. Therefore, these authors conducted a randomized trial in non-expert endoscopists, comparing adenoma detection rate between AI and non-AI, which is the control group. So they performed a randomized non-inferiority trial, performed in 5 centers in Europe, 4 in Italy, 1 in Switzerland. They included only non-expert endoscopists who they defined as the colonoscopy volume in their lifetime of less than 2,000. The patients who underwent colonoscopies were aged 40 to 80 years, who were undergoing colonoscopies for a variety of reasons, including primary screening, positive fit test, post-polypectomy surveillance, and diagnostic colonoscopy for symptoms, for example, anemia. So this randomized trial comprised 2 groups. 1, which was the control group, as in they just performed the colonoscopies as they would normally, and 2, which was aided by artificial intelligence using computer-aided polyp detection program called GI Genius, which is made by Medtronic. So they ended up enrolling 333 patients in the AI group and 330 patients in the control group. As you can see, the mean ages were about 62 years old, about evenly split between male and females. As you can see, the most common cause for undergoing colonoscopy in this group was surveillance post-polypectomy, comprising about 38% of the patient population. About 2/3 of patients had no history of adenomas. As you can see, the mean insertion time was about 8.2 minutes, and mean withdrawal time was about mean withdrawal time was about 8 minutes. Now, if you're looking at the adenoma detection rate, the study showed that the adenoma detection rate was significantly higher in the AI group at 53% versus 44.5% in the control group. When looking at the detection of non-advanced adenomas versus advanced adenomas, as you can see, the AI group had a significantly higher rate of detection of non-advanced adenomas at 40.6% versus 32% in the control group. When they performed subgroup analysis to look at the size and category of, the sizes of the polyps detected, there was no significant difference between the 2 groups when comparing between the different sizes, going all the way from less than 5 millimeters to greater than 10 millimeters. If you look at the type of morphology of adenomas detected, they found no significant difference whether the lesions were polypoid or non-polypoid. However, as you can see, the p-value for non-polypoid lesions is 0.061, and so it's trending towards significance, although not quite meeting statistical significance of less than 0.05. So what these authors did was they pulled the results from the first randomized trial that these authors conducted, where they looked at the adenoma detection rate between AI-assisted and non-AI-assisted colonoscopies among expert colonoscopists, and then results from this randomized trials where they included only non-expert endoscopists. And they looked at, and they performed a regression analysis to look at the factors associated with high adenoma detection rate. And as you can see, use of AI was significantly associated with an increase in your adenoma detection rate. However, as you can see, whether the endoscopists were experienced or non-experienced was not a significant factor, with 95% confidence interval spanning 1 and ranging from 0.89 to 1.16. The limitation of this randomized trial is that the power calculation performed for primary outcome was for the primary outcome only and not for secondary outcome measures. AI assistance was not compared with alternative education interventions such as short retraining courses, which have been known to increase adenoma detection rate in non-expert endoscopists. So the main take-home point from this randomized trial is that non-expert endoscopists have a similar increase in adenoma detection rate by the use of AI as expert endoscopists, especially with flat lesions. Early rather than late integration of artificial intelligence for non-expert endoscopists should therefore be considered. Our second study is published by Dunn et al. In Elementary Pharmacology and Therapeutics. And this is a long-term follow-up of a randomized controlled trial looking at Carvedilol versus endoscopic band ligation for prophylaxis of variceal bleeding. Several randomized trials have demonstrated the efficacy of non-selective beta blockers for both primary and secondary prevention of esophageal variceal bleeding. And current guidelines do recommend endoscopic band ligation and beta blockers in patients with variceal bleeding history, with combination therapy thought to be advantageous over monotherapy in the secondary prevention of variceal bleeding. Carvedilol is a non-selective beta blocker with additional alpha adrenergic effect, with greater reduction in hepatovenous pressure gradient compared to other non-selective beta blockers such as propranolol or nadolol. So the aim of this study was to look at long-term survival in a cohort of patients who were previously randomized to receive either Carvedilol or endoscopic band ligation following esophageal variceal bleeding. So they looked at 64 patients who were recruited to a randomized trial, comparing Carvedilol versus endoscopic band ligation for secondary variceal bleeding prophylaxis. And this original study was conducted between 2006 and 2011. And these authors extended the follow-up up till April 2020. So the patient cohort that was enrolled originally were cirrhotic patients with endoscopically proven esophageal variceal bleeding. The study was conducted in the UK, and these patients were randomized after initial endoscopic therapy to Carvedilol or to endoscopic band ligation performed every 2 weeks until complete eradication of varices. And the primary outcome in this extended follow-up of these patients was transplant-free survival. So as you can see, they have 33 patients in the Carvedilol group and 31 patients in the band ligation group only. And as you can see, the MELD scores were 13 and 14 respectively in the two groups respectively. And a striking thing about this study was that there's quite significantly majority of patients had alcohol etiology as their etiology for cirrhosis. When looking at survival after extended follow-up, if you look at the intention to treat analysis, which is when you follow patients and analyze the results according to their originally assigned group. So if the patient was originally assigned to carvedilol, they will stay in the carvedilol group regardless of crossover to the alternate arm. And as you can see, if you look at the intention to treat analysis, there was no significant difference in survival between band ligation and carvedilol. But if you look at the protocol analysis, where you look at patients not according to what groups they were originally assigned, but what treatment they ended up getting. If you look at that, there was a significant difference between the two groups, with survival benefit seen in the carvedilol group compared to band ligation. If you're looking at the causes of death, liver failure was the cause of death in a significantly high proportion of patients in the band ligation group at 22% versus 0 in the carvedilol group, according to the per protocol analysis, with p-value of 0.004. If you look at the intention to treat analysis, though, there is still a considerable difference of death from liver failure with the carvedilol group. Death rate from liver failure of 9% versus 25% in the band ligation group, although this did not meet statistical significance. However, this is likely due to the small sample sizes in the two groups. When looking at causes of death from GI bleeding, cardiovascular causes, sepsis, and hepatocellular carcinoma, they found no difference between the two groups. They also looked at the probability of decompensating from the underlying liver disease requiring hospital admission. And as you can see, patients who underwent band ligation only were more likely to be admitted to the hospital from decompensated liver disease. The main limitation of this data is that they did take patients that they enrolled in a randomized trial originally. However, the long-term follow-up that they extended beyond another 9+ years was retrospective in nature, with the inherent risk of bias associated with retrospective studies. Also, there's a relatively small number of patients in the two groups, only 33 in carvedilol versus 31 in band ligation. And also, due to the retrospective nature of this study, the compliance to treatment throughout the follow-up period could not be guaranteed by the authors. So the main take-home point from this study is that following esophageal variceal bleeding in cirrhotic patients, carvedilol is associated with survival benefits, fewer liver-related deaths, and fewer hospital admissions with decompensated liver disease. Although long-term follow-up from prospective studies is likely required to confirm these study findings. Our next study is comparing the different modalities for staging liver fibrosis in patients with non-alcoholic fatty liver disease. This was published by Imaggio et al. In Clinical Gastroenterology and Hepatology. Non-alcoholic fatty liver disease is the leading cause of chronic liver disease worldwide, with estimated prevalence of 25% in the general population and 90% in obesity and 60% in type 2 diabetes. Liver biopsy is considered the gold standard to assess a degree of liver fibrosis in non-alcoholic fatty liver disease, but it is associated with high cost and potential risks from the procedure itself. And so there is increasing risk of non-invasive assessment for liver stiffness in patients with non-alcoholic liver disease. And the three mainly used non-invasive methods currently are MR elastography, vibration-controlled transient elastography, which is FibroScan, and 2D shear wave elastography, also known as 2D SWE, which is what I'll be referring to these modalities as, because they're very long names. So the aim of this study was to directly compare the ability of MR angiography, the vibration-controlled transient elastography, and 2D shear wave elastography and non-invasive assessment of liver fibrosis. So this was a prospective study performed in Yokohama, Japan, over a 2-year period. They enrolled 201 patients who all had undergone liver biopsy previously with proven non-alcoholic fatty liver disease, who then all underwent MR angiography, fibroscan, and 2D shear wave elastography. So as you can see, looking at the baseline characteristics of these 201 patients that they enrolled, the mean age was 61 years, body mass index was 27. As you can see, the HbA1c mean was 6.2. Can everybody please mute your microphones? There's somebody coughing and we can hear. Thank you so much. Okay. They were, the proportion of patients with NASH was 138 out of 201, so about 2/3 of patients. Now, what they did was they did a direct comparison using the area under the receiver operating characteristic curves between 3 modalities. And what they did was they looked at the area under the receiver operating characteristic curves for the 3 different modalities according to the different stages of liver fibrosis. So as you can see, when they do a direct head-to-head comparison, between MRE and fibroscan, MRE and 2D elastography, and between fibroscan and 2D elastography. As you can see, there is no difference between these 3 groups, among these 3 groups with each other when it comes to fibrostate 1, 2, and 3. But if you look at stage 4 fibrosis in these patients with non-alcoholic fatty liver disease, MR angiography was significantly better than fibroscan, and MRE was significantly more accurate than 2D elastography. There was no difference between fibroscan and 2D elastography for stage 4 fibrosis, though. It also looked at intra and inter-observer reproducibility. And as you can see, with MR angiography, the intra and inter-observer reproducibility was extremely good, exceeding 0.9 basically for both intra and inter-observer reproducibility between 2 operators. The main limitation of this study is that liver biopsy is the gold standard, but it is not perfect and can be limited by sampling error. The identification of regions of interest of MRE and 2D elastography are not yet standardized. And in the study, which was conducted in Japan, obviously only Japanese patients were included in the study and therefore may not be generalizable to populations from other countries who may have higher BMIs. The main take-home point is that MR angiography, fibroscan, and 2D elastography demonstrated high diagnostic accuracy in detecting liver fibrosis in patients with NAFLD. And however, the MR angiography demonstrated the highest diagnostic accuracy for stage 4 among the 3 modalities, and intra and inter-observer reproducibility. Our last study is a study published in Gastroenterology by Lee et al., looking at association of body mass index at different ages with early onset colon cancer. So the incidence of colorectal cancer in younger adults is increasing in many countries, and BMI is associated with colorectal cancer risk, and there is increasing prevalence of obesity among younger generation. So the aim of these authors was to evaluate the association of BMI at different ages during early adulthood with early onset colorectal cancer. So these authors performed a population-based case control study in Germany, and they've been collecting data since 2003, so almost 20 years. So what they did was they looked at the incidence of, so they looked at patients with colorectal cancer, which are the cases, and they compared it to patients who are controls, who don't have colorectal cancer, but who are matched to patients with colorectal cancer by age, gender, and the county of residence. And what they did was they took these two groups, colorectal cancer patients, individuals without colorectal cancer, and they compared a variety of baseline characteristics, including body mass index, to look at the risk of colorectal cancer according to the different predictive variables. So as you can see, there was some underlying baseline characteristics were different between cases and controls, because obviously they were matched for age, gender, and their address, basically. And as you can see, there was some difference between cases and controls according to whether they were according to their smoking status. So as you can see, there are more current smokers in the cancer group compared to the control group. There's also a significant difference in alcohol consumption, the degree of physical activity, history of colorectal cancer in the first degree relative, which is higher in patients with colorectal cancer compared to those who are not. Also, as you can see, the patients who have colorectal cancer also had high proportion of patients who had never undergone a previous colonoscopy. And this compared to controls, and this difference was significant. So with that in mind, they looked at the risk of colorectal cancer between, so what they did was they looked at patients with colorectal cancer and those without colorectal cancer, and they looked at the impact of body mass index at different ages and their association with colorectal cancer. So here, if you look at the last column, this is adjusted odds ratio, which means they adjusted for all the predictive variables that we looked at in the previous slide. So this is the take-home point. They looked at the individual's BMI at age 20. And if you look at those patients with individuals with BMI of greater than 30, if you had BMI of more than 30, you are 2.56 times more likely to develop colorectal cancer than those. If you look at BMI at the age of 30, if you are obese with BMI of more than 30, you are 2 times more likely to develop colorectal cancer. When they looked at BMI about 10 years before colorectal cancer diagnosis, again, being obese was associated significantly with the risk of developing colorectal cancer. So the main limitation of this study is that they were unable to adjust for all potential confounders associated with colorectal cancer. And for this study, mainly the dietary confounders. So this is the main take-home point from this study. Being overweight and being obese in early adulthood was strongly associated with increased risk of early onset colorectal cancer. And this study therefore supports the suggestion that recent increases in prevalence of obesity in younger generations may be an important factor in the increased incidence of early onset colorectal cancer in many countries. Therefore, measures to prevent or curb the obesity epidemic in younger generations are likely to be crucial for preventing colorectal cancer and calls for consideration of obesity in developing personalized screening strategies for colorectal cancer. So to recap, non-expert endoscopists have a similar adenoma detection rate, adenoma detection rate increase by the use of artificial intelligence assistance during colonoscopy as expert endoscopists, especially with flat lesions, and early rather than late integration of artificial intelligence for non-expert endoscopists should be considered. Following esophageal variceal bleeding in cirrhotic patients, Carvedilol was associated with survival benefit, fewer liver-related deaths, and fewer hospital admissions with decompensated liver disease. MR angiography, FibroScan, and 2D SWE demonstrated high diagnostic accuracy in detecting liver fibrosis in patients with FLD, but MR angiography especially demonstrated the highest diagnostic accuracy for stage 4 detection compared to the other two modalities, and also displayed the highest intra and inter-observer reproducibility. Being overweight and obesity at early adulthood are strongly associated with increased risk of early onset colorectal cancer. And so the study supported suggestion that recent increases in prevalence of obesity in younger generation may be an important factor in the increase in the incidence of early onset colorectal cancer in many countries. And therefore measures to prevent or curb the obesity epidemic is likely to be crucial for preventing colorectal cancer, and also stresses the importance of consideration of obesity in developing personalized screening strategies. Thank you so much again for joining us this month. Our next monthly journal club is on May 4th, 2022, which is the first Wednesday of May. Thank you so much again. Have a wonderful day, week, and month. Thank you so much again, everybody. Goodbye.